All right, so we're going to look at respiration and also SaO2. Uh, so one of the things I want to kind of show you is to think in terms of respiration in terms of our acid-base balancing. And so when we look at what drives respiration, whether we have normal respiration, we're tachypnic, or we have low respiration, the driver for that is the central chemoreceptors. So we have peripheral chemoreceptors and we have central chemoreceptors. The central chemoreceptors respond very strongly to things like hypercapnia, where I've increased my CO2. So if I look at blood, my level of CO2 in the blood helps determine my respiration rate. And so CO2 can diffuse out of blood into cerebrospinal fluid. Now, in cerebrospinal fluid, CO2 can join with H2O to form H2CO3, and then of course that can dissociate into a bicarbonate ion and a hydrogen ion. These hydrogen ions, what they'll do is they'll start to lower the pH of cerebrospinal fluid. Now, cerebrospinal fluid is already lower than serum, and that's because it doesn't contain the protein buffers that serum has. So let's say my pH in here is 7.40. My pH already in here is about 7.33. Now, if I start to add hydrogen ions to that, what that's going to do is that's going to take my pH and drop it even lower. And so one of the things that I'll see is that if I drop this from like a 7.33 down to a 7.25, you'll double your alveolar ventilation rate. Now, my PCO2 in here is usually around, in the arterial PCO2, it's about 40. And this is maintained within a plus to minus 3 millimeter of mercury range within that 40 millimeters of mercury for PCO2. Likewise, if I were to change this, like if I were to bump this up to say a PCO2, arterial PaCO2 of 45, once again I'll get more CO2 diffusing into cerebrospinal fluid, forming carbonic acid dissociating hydrogen ion, and once again I'll see my alveolar ventilate double. And so usually if a patient is tachypnic, a lot of times you have to think of hypercapnia because they're increasing their PCO2. Now, if somebody has COPD, of course, this is off the table because in chronic COPD and emphysema, this is chronically elevated and these central chemoreceptors no longer respond to that. At that point, it's going to be the peripheral chemoreceptors. All right, so we're going to just look at some things that we have to think about when we're looking at respiration. So what we're not looking at right now is not looking at quality of respirations and things like that. We're just looking at the rate. And so if we think in terms of acid-base balance, again, we've got my acid side of the scale here, and this is controlled by respiration. We've got my alkaline side of the scale here, and this is considered metabolic, and this is typically considered controlled by the kidneys because I'm going to either conserve or get rid of bicarbonate. So over here I have H2CO3, and over here I have bicarbonate, and as we've already pointed out numerous times, this is a 1:20 ratio. And so for every 1.2 milliequivalents of carbonic acid, I have about 24 milliequivalents of bicarbonate. All right, so there's a 1:20 ratio. All right, so if a patient has a let's say they're typically what's taking place is this side of the scale is responding to something over here. It's compensating for something. But that's not always the case because think about your patient that has too many opioids in their system or too much benzodiazepine or barbiturates or alcohol. What's going to happen is that's going to start to slow everything down. And so as they start to slow everything down, normally I'm breathing off CO2, but it's being derived from H2CO3. So normally I'm breathing this out. But now what's happened is that those opioids, benzodiazepines, alcohol, barbiturates, they've decreased my respiration, and since I'm not breathing it out, I'm actually adding it over here. And so in that case, I didn't compensate for anything over here. I just started to load the scale, and I'm going into respiratory acidosis. On the other hand, you might have a patient that had a head injury, a patient that has anxiety. In this case, they're actually driving the pathway this way. And so now they're unloading this side of the scale, and since they're unloading the respiratory side and taking the acid away, they're sending themselves into respiratory alkalosis. Now, typically, clinically what you're going to see more is compensation. And so usually what we're seeing compensation on this side for something taking place on this side. So we're going to look at two different rates, and we're going to talk about some considerations. So let's look at a patient that has a slow breathing rate. And so a slow breathing rate, we said, would be compensation because a slow breathing rate is going to increase my H2CO3 and increase the carbonic acid, in order to drop my pH, because I'm compensating for something over here, some type of alkalosis. The example I gave you with the case study is a patient that was taking sodium bicarbonate. And as the bicarbonate levels increased, what they did is, as bicarbonate levels increased, it actually started to make my blood more alkaline. And here we saw that as we can see that as the blood becomes more alkaline, what we want to do is we want to make it more acidic. And so we're going to start to slow our breathing rate and retain that. Okay, another example I just wanted to give you was up here, diabetic ketoacidosis. So our patients with diabetic ketoacidosis, they come in really rapid respiratory rate. Because what's happened is, if they don't have insulin and they can't get glucose into the cell, the body starts to go into ketone production. And so there's a few different ketones that we have. I'm looking at acetoacetic acid. So this is the form of acetoacetic acid as a ketone in the blood. However, at a pH of 7.4, what's going to happen? So if my pH is 7.4, this is going to dissociate in blood. And so what I'm doing is I'm giving this up. And so what I end up with is this double bond here. I gave up the hydrogen, and now what I've done is I'm in that acidosis. So diabetic ketoacidosis is occurring because I'm taking these acids and I'm liberating the hydrogen ion. Now, if we look at somebody's serum metabolic panels, what we'll start to see is a drop in bicarbonate, okay? And the drop in bicarbonate is because of this. When I have the hydrogen ion, I need to get rid of that. So I'm going to take that hydrogen ion and I'm going to bind it with a bicarbonate ion. And now what I've done is I've removed it from this side of the scale. When I removed it from that side of the scale, I took it off the metabolic side. It's going to tip to the acid. So my diabetic ketoacidosis is a metabolic acidosis. But now look what I'm going to do. I'm going to take that hydrogen ion and I'm going to give it right here to H2CO3. Now I'm in a world of hurt if I don't do anything, because I took a bicarbonate off the alkaline side, joined it with a hydrogen ion, but then I took that acid and put it on this side of the scale. If I don't do anything about that, I'm going to get really acidic. But my response now is going to get unloaded this side of the scale. So as I'm unloading this side of the scale, tipping it this way and adding the carbonic acid over here, I start to breathe rapidly to get rid of this carbonic acid and then breathe it off. And so your patients will be in metabolic metabolic acidosis, but they're going to compensate by trying to move into respiratory they're in metabolic acidosis, and they're going to compensate by blowing off the H2CO3 and moved into respiratory alkalosis. Okay, so when you're looking at respiration and looking at rate, try to think about, is it a primary something? Are they trying to compensate for something? And then also think of the drivers, because an increased hypercapnia is a strong driver, because CO2 is diffusing in to cerebrospinal fluid and liberating the hydrogen ion, but also plasma pH is also a driver of it. Okay, so another thing we want to look at is SaO2. So with SaO2, I'm going to review your oxyhemoglobin dissociation curve. So SaO2 just gives you an idea of what the PaO2 is based upon the SaO2. Now, if we looked at the PaO2, let's say your PaO2 was reading 90, let's say it was reading 100, okay? Or not, your PaO2 is reading 100. Let's say that your PaO2 was at 100. Well, I know that if my PaO2 is at 100 and my pH is normal, so it's within that range of 7.35 to 7.45, but let's say it's 7.4, and let's say my temperature is normal, it's at 37 degrees Celsius, I know that at 100, I'm almost 100% saturated, all right? Now, I also know that when a red blood cell goes through the entire system, it leaves the heart, it goes to the foot, it comes back to the heart. In that transit, it's given up 25% of its oxygen. And so I know that when it comes back, it's at 75% and it's at a PaO2 of 40. So here I am, 75%, and my PaO2 is at 40. Now, if I also know this, that if I, with my COPD patients, if I have a COPD patient and I put the pulse oximeter on their finger, if their temperature is normal and their serum pH is normal, what I would expect is this, is that they would be at 90% on their SaO2, and I know that their PaO2 is at 60 millimeters of mercury. So if they're reading, again, if their SaO2 is reading 9%, their PaO2 is at 60. I know that based upon this curve. But that's only if their pH and their temperature are being controlled for. So if I have a patient and their SaO2 is reading 90, but they are febrile and they're in acidosis, then I also know that they're not going to be at 60 because it has shifted my curve over this direction. So what's going to happen is they may be reading, so what's going to happen is this, is that the whole curves get shifted over. If I want to maintain 90, I'm going to have to come out here and bump them up higher in order to maintain that 90. So I have a patient, they're at 82. Okay, I know that their pH is, they're in acidosis, they're febrile, and so what I'm going to do is I'm going to go in and I'm going to turn up that nasal cannula. I know there's considerations with hypoxic drive, and we're going to deal with that later, but I know that with Henry's law, it tells me that if I can increase the partial pressure, I can increase the movement of the gas into plasma, and I can increase this bonding right here. So if, again, what I would want to do is to get them from that 82 back up to 90, is increase their nasal cannula. So normally at room air, you have a fraction of inspired oxygen at 20.9%. And so I know that for every 1 liter of O2, I put them on nasal cannula, that's going to increase their FiO2 of 2 to 3%. And so bottom line is they should respond to that. So patients should respond to the administration of oxygen by nasal cannula in these types of situations. However, let's say that you have somebody that's refractory to it. I'm getting an SaO2 of 85%. So I know that if I put them on nasal cannula, oxygen, that I'm going to start increasing that FiO2. So I start turning it up, but nothing's happening. Well, then I have to think, okay, what's taking place at this point? And now what I'm going to consider is what's happening between the alveoli and the endothelial cells. Because this membrane right here is only about 0.5 to 1.5 micrometers thick. Now, normally a red blood cell is in this circuit for only about 750 milliseconds. It only takes about 250 milliseconds for it to become completely saturated. So as long as I'm putting them on nasal cannula and bumping up the P big A, stands for alveolar O2, their P little a should be going up also. But if it's not, then something else is taking place. Well, one thing I know is that oxygen has a poor solubility coefficient. So if there's pulmonary edema in here, it's harder, even though I've increased the PaO2, I'm not getting an increase in the P little a, arterial O2, and my SaO2 is not going up. So once again, SaO2, you're thinking if it's refractory, if it's not going up, there's something happening in the lungs, like inflammation, or it could be with acute lung injury or acute respiratory distress syndrome that they're just not getting the oxygen from the alveoli into there. Okay, so the last thing I just wanted to mention, and your notes will go into more detail on this stuff, but the last thing I wanted to mention is temperature. So with temperature, one of the things you always have to ask yourself, is the patient pyrexic or are they febrile? Because you can have a patient that is pyrexic, but they don't have a fever. So I've got 2 patients. I have both of them, let's say they have 102 temperature. I might have one that has pyrexia and one that has a fever. Well, fever, it indicates infection. Because if I look, let's say that this one, I know that they had like pneumonia. Well, that's a fever, because when a macrophage ingests a bacterium, that macrophage, once it takes it in through phagocytosis, will release IL-1. IL-1 will circulate to the hypothalamus, where it activates the arachidonic pathway and stimulates the COX-1, COX-2 enzymes to synthesize prostaglandins that will reset the hypothalamic thermostat. So this person is shivering in response and creating thermogenesis in response to interleukin-1. So this would be a fever. On the other hand, I might have a patient that has a temperature of 102, but they don't have an infection. That would be pyrexia. And so I might have somebody that's in thyrotoxicosis. There's something else driving the temperature other than an infection. All right, so we're going to stop it there. If you have questions on any of this stuff, you can always email me. Other than that, just reference your notes and we'll give you more information on this stuff.